Hi guys, welcome back to my channel. My name is Ziad, Crohn's disease patient, NHS worker and educator, here bringing you IBD facts and taboo breaking chats. Don't forget to like, comment, share and subscribe on my channel. So let's get started. Hello and welcome to this lesson all about female fertility and IBD. So regardless of your gender or sexual orientation, sexual health is an important aspect to an individual's health and well-being. Sexual health is not limited to the absence or presence of disease and includes the engagement of and enjoyment of intercourse in a safe manner. The risk of sexual dysfunction in both men and women with IBD increases due to the impact of IBD has on the overall health of that person, as well as the impact of medication, surgery, and mental health causing issues with body image. In women, they can also suffer with something called Vaginal Crohn's disease, with most vulvovaginal lesions relating to Crohn's disease being linked to fistulas that arise from the anus or the rectum, such as rectovaginal fistulas. The vulvar manifestations of Crohn's disease are typically asymptomatic and can often precede an IBD diagnosis, but symptoms such as itchiness, pain during sex, burning, stinging during urination, and vulvar pain and discharge have been described. Physical presentation of vulvar lesions include swelling of the vulva that can affect the vaginal wall, labia minora and majora, superficial or deep knife-like ulcerations that can extend into the groin, and hypertrophic lesions that can infiltrate the entire labia. This complication of Crohn's disease can be painful, cause pain during sex, and mental health issues relating to body image, resulting in reluctance to be intimate. So let's move on and look at fertility in women with IBD. So first we're going to look at contraceptives. Now contraceptives are used to help prevent any unplanned pregnancies and the spread of any sexually transmitted diseases. While there are many methods of birth control available, the type that will be best suited to you will depend on a number of factors. And one of these factors is how your IBD actually affects you, as well as the medications that you take. In women where their IBD is active, it has been seen there is an increased risk of health problems and complications during pregnancy with active disease. It has also been seen that some medications used to treat IBD, such as methotrexate and mycophenolate mofetil, can cause birth defects and increase the risk of miscarriages. So it is advised to use contraception for up to 6 months when stopping these medications under the advice of your doctor, as they can remain in the body for that period of time. Women should be cautious when taking the combined oral and the progestogen-only contraceptive pill, as they are more at risk of developing blood clots when taking oral contraceptives, which further increases if having surgery and are required to stay in hospital. In women with Crohn's disease of the small intestine who suffer from malabsorption or who have had a portion of a small bowel resected away should also be aware that inflamed or scarred portions of their bowel impairs the ability of the intestine to absorb the contraceptive pill. This causes the full dose of the birth control to not be taken up by the body. This also applies to if you're experiencing symptoms such as diarrhea and vomiting, and so other forms of female birth control such as the contraceptive patch, injections, implants, or the coil should be considered to avoid any unwanted pregnancies. Barrier methods of contraception such as condoms, cervical caps, and contraceptive sponges all help prevent sperm from entering the woman's uterus. Some of these barrier methods contain spermicides, which is the name given to something that kills sperm, but some don't, and so you may need to apply it yourself. For example, when using a diaphragm, which is a form of female barrier contraception. Now, it can be difficult to determine the true impact IBD has on fertility and reproduction, as many studies do not consider what is known as voluntary infertility, where many choose not to have children out of the fear of passing on their IBD to them. In recent studies, voluntary infertility has been reported as the main reason for infertility, while patients often see pregnancy with IBD as undesirable due to lack of information provided to them. It is thought that women with Crohn's disease can potentially have decreased fertility due to the inducement of inflammation in the ovaries and fallopian tubes and dyspareunia due to perianal disease. It is recommended to try and strive and attain for remission before trying to conceive. Many women can often experience a reoccurrence of their IBD symptoms because of the hormonal changes in their body leading up to their menstrual cycle, and some notice a change in their bowel habits or an increase in their IBD symptoms just before and during their period. It is unknown if women experience increased pain from menstruation due to their IBD, but it may not be unlikely as some other health conditions are known to aggravate menstrual symptoms. Having heavy periods can increase the risk of iron deficiency anemia, which can impact on quality of life, contributing to fatigue, which is usually one of the most common problems people with IBD face. There is also very little knowledge on the effects of IBD and menopause, because some women with IBD may be diagnosed with their IBD during or after menopause has occurred. Women who reach the age of 50 will stop having periods due to menopause, of which hormone replacement therapy can be used to reduce the symptoms. Hormone replacement therapy works by replacing estrogen that the body stops producing when you go through menopause. However, despite the risk of HRT, which can include blood clots, breast cancer, and development of ulcerative colitis, it has been suggested that it may provide a protective effect for disease activity in the postmenopausal women due to possible anti-inflammatory effects of estrogen. So there is currently very little evidence to suggest that medications used to treat IBD has any impact on fertility and ability to conceive in women. But when we look at surgery, women who require abdominal and pelvic surgery are at an increased risk of subfertility, which is the inability to conceive within a year. This is because procedures such as an iliopouch anal anastomosis or IPAA, ileostomy or colostomy surgery occur around the abdominal and pelvic area, and so can cause damage to the reproductive organs due to the invasiveness of the procedures. Additionally, fertility can be impaired due to the formation of adhesion and scar tissues obstructing the fallopian tubes, and so it has been suggested that where possible, laparoscopic approaches, so keyhole surgery, should be used to reduce the risk of affecting fertility. Now, concerns over the impact of IBD medication or surgery on fertility and the ability to conceive in the future are valid among those with IBD, and there are a wide range of fertility preservation options available to women, which include egg freezing and ovarian tissue freezing. Now, the fertility preservation options used can be used in combination with male fertility preservation techniques until a female is ready to undergo infertility treatment. Now, infertility treatment is commonly known as IVF. However, IVF is just one type of procedure that is used in infertility treatment. So let's look at pregnancy and IBD. So it has been seen that the risk of having a flare-up when getting pregnant during remission is the same as the risk of a non-pregnant IBD female, and that women with ulcerative colitis actually have a higher risk of having a flare-up within the first 2 trimesters. It has also been thought that pregnancy can have a positive influence on IBD activity, and those women who have had previous pregnancies need fewer surgical interventions, and that the time between operations were longer compared to those women who have not had a child. It is recommended to achieve pregnancy during remission, as pregnancy during active disease increases the risk of increased IBD activity throughout the pregnancy. It is thought that the use of aminosalicylates are generally safe to take during pregnancy, despite sulfalazine interfering with folic acid uptake. There is still research being done looking into the effects of biologics on pregnancy, but there is evidence to suggest that they are generally safe to take when trying to conceive and during the first trimester. Anti-TNF drugs like adalimumab, golimumab, and infliximab are too large to pass through the placenta during the first trimester. However, both adalimumab and infliximab start to closely resemble maternal immune cells during the second trimester, and so can be transported to the unborn baby. There is still not enough information available on the effects of anti-integrin drugs and anti-interleukin drugs, so vedolizumab and ustekinumab, in pregnancy. Even though small amounts of corticosteroids can pass through the placenta during pregnancy, they are metabolized into less active substances, and so medications such as prednisolone are still considered safe to take during pregnancy under the guidance of your doctor. When it comes to immunosuppressants, azathioprine and mercaptopurine can be taken during pregnancy to help in maintaining remission of IBD, as there is a risk to the unborn child's health if a flare-up occurs. But even though azathioprine can pass through the placenta and its metabolites can be detected within the blood of the umbilical cord, studies have suggested this risk to the baby is minimal. However, it is advised that pregnant women should not take methotrexate or mycophenolate mofetil when pregnant due to the risk of developing birth defects and miscarriages. When it comes to tacrolimus, there is little evidence to suggest that it can cause any adverse effects during pregnancy. However, advice from doctors should be sought if wanting to conceive or are currently pregnant and taking tacrolimus and cyclosporin. When it comes to childbirth, the decision of how to deliver a child should be made with input from both an obstetrician and your gastroenterologist, due to the impact a delivery can have on the pelvic floor and bowel sphincters. In general, most women with IBD can have a normal vaginal delivery, as can those who have a stoma. Those women who have scar tissue around the anus due to their IBD and opt for a vaginal delivery may require an episiotomy, which is making an incision at the opening of the vagina to make it wider, to allow the baby to pass through easier and prevent any tearing. However, episiotomies should be avoided where possible when perianal disease is involved. In women who have had IPAA surgery, active perianal disease, or active rectal involvement may be advised to have a caesarean section. This will depend on the extent of perianal disease involvement and how intact the bowel sphincter and pelvic floor function is post-IPAA surgery, as this group of people can be classified as borderline incontinent. A caesarean section will help reduce the risk of damage to the anal and pelvic muscles and sphincters which might occur during a normal vaginal delivery. Now, a C-section should be discussed during antenatal appointments, as it can be necessary to have one during emergencies, and some women may opt for a C-section instead of a vaginal delivery. Now, many women after childbirth have concerns about breastfeeding when on IBD medication. But some aminosalicylates and corticosteroids can pass into the breast milk in small amounts, but it is still considered to be generally safe to take them while breastfeeding. However, some babies who are being breastfed by mothers on aminosalicylates may experience diarrhea, which usually resolve once breastfeeding or the medication has stopped. Research is still being conducted on breastfeeding while on biologics, and so it is not yet known to what extent some biologics can be found in breast milk or what effects they may have. Some preliminary studies have shown that anti-TNF drugs like infliximab could be found in breast milk, but it is thought that because these drugs are large molecules that there is a minimal chance they would be absorbed by the infant. With vedolizumab and ustekinumab, it has also been found in breast milk by some studies, but in very low concentrations, and is also thought to be unlikely to cause any harm to the infant. With immunosuppressants such as azathioprine, they can be taken when breastfeeding despite small amounts being able to pass through into breast milk. However, there is no evidence that this causes harm to children who are being breastfed. On the other hand, mycophenolate mofetil, methotrexate and tacrolimus are not recommended when breastfeeding, as they can pass into breast milk and affect the child's immune system and should be avoided during breastfeeding. Again, any concerns you have about medication you're taking while breastfeeding should be discussed with your doctor. So to summarize, we have looked at how IBD can affect female fertility, as well as looked at the impact of IBD on pregnancy and on breastfeeding.